So thank you very much for inviting me to come and talk, and I'll just start by talking about pediatric hand fractures, which probably in my practice maybe makes up about 20 to 25% of my trauma that I see. It's the most commonly injured part in children because they're inquisitive, they put their fingers where they shouldn't be putting their fingers, and it tends to have a bimodal distribution with the small children and then the adolescents again who get sports-related injuries. The problem is that we need to recognise which injuries need additional attention, because most of the finger fractures actually will heal just fine with a little bit of buddy taping or a little bit of a splint or a cast. But there are particular fractures that need additional attention, and so they're the ones that I'll talk about most this morning. The patterns that I'll go through, I'll talk about the Salter-Harris fractures of the fingers, I'll talk about phalangeal neck fractures, intra-articular fractures, metacarpal fractures, a little bit about avulsion fractures, and then right at the end just a little tiny bit on fingertip injuries. For me, examination is the key to diagnosis and also determining a lot of what needs to be done in addition to the radiographs. Just looking at the finger out straight can be quite deceiving, and that needing to get the child to bend, getting them to bend naturally can be very hard. They're not very cooperative, and so therefore I use a lot of just tenodesis effect and watching what happens with the hand when it moves. Also with children, they won't tell us if they've got a nerve or a tendon injury associated, and so therefore I have a very high index of suspicion, and we'll use topographic anticipation, just knowing where the anatomy is, to really hone in on what might be injured, and sometimes I have to just explore to find out. So malrotation can be very deceiving. It can actually look completely normal when the finger is out straight, and it's only when you bend it down that you see the rotation. We know that the small finger can underride the ring finger, but if you can compare to the other side, you can see if there's a difference. I find deciding when to do a radiograph hard, so I have a very low threshold for doing radiographs, because children, they actually will just get on with life very quickly and can actually have a significant injury and completely use their hand fairly normally. I look for what the finger looked like when it was first injured, so did it stick out to the side? I look at the mechanism, and I also then look at my clinical examination findings. In terms of the radiographs, they can be a lot harder than adult radiographs to interpret, especially the very small finger. And sometimes just the tiniest fleck of bone can actually mean that the whole condyle or whole phalangeal head has come away from the finger, especially in the under 2 and 3-year-olds where they haven't necessarily ossified their epiphyses yet. The other thing that can be deceiving is to remember where the IFICS are, that they're proximal on the phalanxes, they're distal on the metacarpals except for in the thumb. And then at the base of the second and third metacarpals, you can be deceived that there might be a fracture because of the pseudoepiphyses, so the ossification centers there that are not associated with growth but look like an epiphysis, and they're present in a number of children. IFICS close in the hand earlier than they close in the extremities, and the upper extremity closes a little earlier than the lower extremity. So remembering that if you've got a 10 or an 11-year-old girl, then their hand is, the fingers are pretty close to skeletal maturity, and you're not going to get very much remodeling. So relying on remodeling can be difficult there. So Salter-Harris fractures, in much of the body, we have a bad reputation for going on to get a growth arrest. In actual fact, in the fingers, it's fairly uncommon, and growth arrests only tend to be problematic when they happen in the under-teen age group. So what we're more worried about is the malalignment, especially when it's the proximal phalanx, because of the magnification for the length of the finger that any rotation will then have on that. The small finger is the most commonly injured, and we call this the extra octave because you can then reach further on the piano if you get this particular injury. It can be quite disabling, putting hands in pockets and catching on things if you miss this fracture. And It's very amenable to close reduction. So I'm sure you've all know this trick of putting the pen in the web space, clamping the finger onto the pen. It's very hard to get purchased just with your fingers right down there, right at the base of the finger, and so therefore getting that pen right down into the web space can be very helpful. Clamp it over the top and then take the pen out, buddy tape the finger, and most of the time, 95% of the time, in actual fact, that's all you'll need to do, keep it buddy taped. However, if you put it in a cast without buddy taping, you can actually find that it displaces. So it is one of the fractures that you must follow up to make sure that it doesn't displace. In terms of needing operative treatment, it's the position of the finger without the buddy tape on. You can always, and I'm sure you've seen this in both fingers and toes, you can always tape a finger back and it will look good until the tape comes off when the fracture's healed, and it will spring back out to where it was. So always the position of the finger without the buddy tape. The buddy tape's very necessary to hold the reduction though. Occasionally, if you do need to pin these, and you'll see that I use a lot of pins, I very rarely do screw fixation in pediatric hand fractures. I get stable fixation often through pins, but I don't worry about moving children's hands early. I just put them into a mitten cast that covers all of their fingers and then let them heal, and then they won't get stiff like adults do in the same sense, as long as the fracture is appropriately reduced and held. The ones that I am very concerned about is where you have multiple phalangeal fractures, and these really, you might be able to get them closed reduced, but holding them with taping when you've got multiple fractures next to each other and then knowing that you haven't got malrotation, which is very common if you've got multiple finger fractures, is hard. And this patient had a closed reduction, and as you can see, the fractures are not in perfect alignment. The fingers look straight, but when I took them out of the cast and I bent them down, they were going in all directions. And so therefore, pinning these fractures is very common in my practice. And sometimes you can do them retrograde, but this is that principle of going from the large fragment to the smaller fragment. It's very hard to get to your target. And so therefore, sometimes I will do them antegrade, coming in through the metacarpophalangeal joint. It's much easier that way, but you're putting your pins inside the joint then, so then you're much more worried about potentially causing a septic arthritis, although that's not very common, just something to be mindful of. As I said, growth arrests are very uncommon, even when you've had a high energy trauma and you've then pinned across the IFICS. I don't worry about putting smooth pins with 1 or 2 passes across the growth plate and that causing a growth arrest. I think that malaligned fingers are going to be much more disabling and much more likely to lead to a functional problem. Another fracture that I have found in my practice that can be sometimes under-recognised and often dismissed is the Seymour's fracture, which is a Salter-Harris 1 fracture of the distal phalanx. And it's not really the fracture that's the problem here, it's the fact that the fracture causes a laceration through the germinal matrix, and that, if not recognised, can cause a permanent nail deformity. It can come in the right-hand picture with it very displaced, and we all get that one easy. We know what to do with that one. But it can also come with the left-hand picture where all you see is the bleeding around the nail fold, or potentially you just see more of the germinal matrix, and it actually looks pretty okay, but in actual fact that whole nail plate has come out from underneath the dorsal nail fold and is sitting on top of it, and this is the one that's going to get infected and it's going to get chronic nail changes. So therefore, we repair these. We do them actually in our emergency room. We don't take these patients to the operating room. We do it with a finger block and some sedation. We always use a digital tourniquet, but whenever we use a digital tourniquet, we have very big things that are attached to the tourniquet. We always leave a snap or a clamp on it, and some of our more commercial products actually have a big tag that can't come off, so that we don't, at the end when we've done our dressing, forget to take off, because the fingers don't really have the same amount of pain because there's no muscle for ischemia if you incidentally leave a tourniquet in place. We repair the germinal matrix, sometimes even with mattress sutures, because you can imagine it's right down at that very bottom. We'll use chromic sutures from the dorsal nail fold, making sure that we keep the nail fold open and splinting it back with the nail. The need to actually put fixation in is not necessary all of the time. You can often just put a splint on the finger and that will hold it there. The smaller the child is, the more likely I am to put a pin in, because that finger is going to be moving inside the cast and even a splint won't hold it still. And if I'm going to put a pin in, I actually displace the fracture, drive it out through the fingertip with a double-ended wire and then back across. I never leave the wire just in the distal phalanx, because it has to get into the epiphysis. It's more likely to end up in the joint, so I cross the joint and I leave that in for 3 to 4 weeks, depending on the age of the patient. Unfortunately, these injuries can and will be missed, and they will go on to get infection. You can see that lysis at the dorsal part of the physis there. As long as it's within the first few weeks and the new nail hasn't completely started growing, we'll still go and take these off, because they're going to end up with a chronic discharging infection if I don't. And if you don't, you do end up with these nail changes potentially. So the next fracture that I'd like to talk about is going on to talking a little bit about intra-articular fracture, and that's the gamekeeper's thumb, or the abduction injury with the ulnar collateral ligament pulling off a piece of bone. In adults, some of these can be managed non-operatively. In children, it's much more of a Salter-Harris 3, and it can actually be like half of the physis and the epiphysis that's come off. And I'll show you in this next picture, you can see that the piece of fracture is quite dorsal. So the adult ones, it's really down on the volar side. For the children's ones, you actually tend to bring your incision a little bit more, not bringing it down into the web space, but more on a dorsal incision because of that bigger piece of bone. The later adolescents will behave more like adults, so they won't behave like this pediatric version. And then pinning these with crossed pinning. These can be tricky, I think. They sometimes will keep displacing. Another fracture that I found is sometimes under-recognised is the phalangeal neck fracture. And this fracture, especially when it occurs in the proximal phalanx, can lead to a great deal of loss of motion, in particular flexion. That spike can impede. You look at the proximal phalanx here, you've got a nice condylar offset. You look distally and you don't have that condylar offset. And the problem is is that when you go to bend down, it will impinge, just like if we turned this upside down and made it look like a supracondylar fracture. If you now think of the shaft as the humerus coming down to the distal humerus, if this was a supracondylar fracture that was extended that far, you wouldn't hesitate to take that to the operating room to pin it. So the same applies for these, especially for the proximal phalanx. Otherwise, you're going to get into trouble. That metaphyseal spike does not necessarily remodel, and any rotational malalignment can't be seen unless you can flex. So sometimes, and not infrequently, these actually turn up later. They turn up at 10 days to 14 days because the parents, if you were in the office for every single finger jam, parents would be in the office all the time. And so therefore, if these turn up and the patient still has any tenderness, then I will use this technique that Dr. Waters published for using a small C-wire intrafocally into the fracture site to break it up. You've got to be careful to make sure you don't get the flexor or the extensor tendon, because if you're windscreen wipering on the tendon dorsally or volarly, you can lacerate the tendon. So you've got to make sure you're intrafocal and that you're inside the bone, but you can feel that when you're doing it. And then using that to lever it back down and then pinning it like you would a supracondylar fracture with crossed pins. If you end up with a malunion, that's where you lose the motion. You can wait for some time. Some small children will resorb that spike. I would tend to give them at least 6 months. The older adolescents are less likely to. And you can see that that bump is going to be difficult. You can actually go in and resect that. That's, to me, a little bit more challenging to get that motion back without causing a fracture through the phalangeal neck. So I'm not sure that if I didn't do a lot of finger fractures that I would go into that one myself. The other fractures that I find are very commonly under-recognised are these small intra-articular fractures. I'm not going to talk about the T and the Y fractures, but I'll talk about these unicondylar fractures, which the same principle applies for the T and the Y. They're just much less common. These unicondylar fractures are really common, and they're really subtle, and they're unstable because they're partial articular fractures. These fractures in my practice all require surgical management. If it's completely undisplaced, I talk to the family, and sometimes we will watch, but we have to watch very closely. It's much easier to pin before it displaces than after it displaces. And as you can see, in an adult, you would use stable screw fixation. It's very, very uncommon for me to use screw fixation even for these unstable fractures. I will pin small pins and I will put them into a cast and I will keep them still. It's much more important to have the joint reduced and they'll get their motion back later. You can reduce these just with the very point-to-point towel clip. If you can't get it reduced closed, then it does need to be done open or sent to somebody who can do it open, because it's the joint ultimately that's going to lead to the disability for the child, not the stiffness from keeping it still. If you can't get them reduced closed, then open reduction, making sure you're respectful to the neurovascular structures and the extensor or flexor mechanism to get back articular congruity. And you'll see here, even though this is a complex intra-articular fracture, we're still using pins to hold it. I do sometimes use screws though, especially with the adolescents, but just not very commonly. Much more common to leave pins, and I'll still leave them out through the skin even if I've done an open reduction, because I can then pull them in the office at 3 to 4 weeks. Phalangeal shaft fractures also, and we've talked about most of the principles to do with these, almost always, if you can't get them to flex down at the first week, see them at the second week, make sure they haven't displaced, and make sure that you can get them to flex down. Sometimes they can actually be quite subtle, but still have significant malrotation, even though the coronal plane alignment looks great. Almost always closed reduction and pinning. Now, just for a couple of things that are a little different that don't tend to require operative treatment, we were always taught that the optimal position for Box's fractures was to cast them in metacarpal plus with the fingers out straight. We don't do that. We cast them out straight, a mitten cast, because children don't get stiff with this injury. And if you want to hold a reduction, it's much easier to get a mould on the metacarpal head with the fingers out straight. And it's even been shown in adults that casting fifth metacarpal neck fractures out straight does not lead to significant digital stiffness. And so in our practice, we will put all fingers into a mitten cast, fingertips free, but we will certainly be using a mitten cast for this fracture. The metacarpal shaft fractures can get us with rotational problems, and so therefore you must examine. And again, sometimes I will use a plate and screws in the adolescents for these, but it's about recognising the rotation and then treating it as the fracture that it is. The metacarpal base of the thumb is different though. We can accept a lot of displacement and deformity and not need to do surgery. As long as you've got less than 30 degrees of angulation in these fractures, they can be managed non-operatively. I will sometimes even do a closed reduction, just getting that thumb abducted, pushing at the base of the metacarpal, and they will commonly reduce into a perfectly acceptable location. In younger children, you can even accept more deformity. I'll skip over the bony mallet, but just make sure the joint is reduced. It's a fairly simple fracture otherwise. And then just one small thing on fingertip amputations is in very small children under 4 years of age, as long as it's distal to the DIP where you wouldn't be able to replant that finger, I still would not do a revision amputation at the start. I will put back on the fingertip it'll look like it's going to not survive, but if you then take your time, some of these children will actually revascularize their fingertip themselves and actually end up with a much better, more cosmetic outcome. So let me just cut the main points. I have a very low threshold for doing plain radiographs. Small fragments in children can actually represent really big injuries. Surgical treatment, commonly pins, occasionally screws, and it's almost always required for Seymour's fractures, 100% of the time in my practice. Displaced phalangeal neck fractures, unless there's a good reason not to, like you're very confident that it's undisplaced. Intra-articular fractures, almost always, and Salter-Harris 3 fractures of the thumb because they're intra-articular fractures and often a bigger piece. I rarely require advanced imaging. Thank you.